morning, everybody, and welcome back to the GISE Clinical Corner. Today's topic will be a structural case, a TAVI case in a low-risk patient with a not-so-lean approach. And I'm very pleased to be here with our expert, Roberto Nerla from Maria Cecilia Hospital, and Antonio Giulio Bruno, our young operator from the University of Bologna. Please feel free to type your question in the chat box, as we'll address it after the clinical case presentation and our experts' insights. So without further delays, I hand over to Antonio, please.
Thank you, Julia. Let's go straight to the clinical case, which is the case of a 57-year-old man with an history of previous chest radiation because of a previous Hodgkin lymphoma. Chest radiation that was complicated with moderate restrictive lung deficiency and atrioventricular block requiring permanent pacemaker implantation. He was referred at our institution in NEA class 3 because of a concomitant severe aortic stenosis. As you can see here, he had an aortic valve area of 0.7 with a mean gradient of 50 and ejection fraction of 55%. Here you can see his angiography. He had no significant coronary stenosis. And here you can find his CT scan data. We believe that the CT scan in this kind of patient is really important during an heart team discussion to establish the most appropriate approach to treat this patient. As you can see, the iliofemoral axis and the HS are not an issue because they are not there are no tortuosity nor severe calcification or stenosis. And the narrowest point on both sides it's about 8 millimeters, so no issue at this level. Here you can see his virtual basal ring data. He had an area of 579 with a perimeter of 86 and a maximum diameter of 29, a minimum diameter of 25. As you can see, he had some bulky calcification at the virtual basal ring that protrudes in the LVOT. The average diameter of valsalva sinuses was 35 and at STJ 13. The coronary arteries were not low. And as you can see here, he had some important calcification of the aortic wall, but we could not define this real porcelain aorta. But of course, this is not an easy clamp for heart surgery. So, in summary, we have a 57-year-old man with severe aortic stenosis, normal ejection fraction, history of previous chest radiation, diffuse aortic wall calcification, previous pacemaker implantation, and low STS, which was estimated to be about 2.1, and no coronary stenosis. So, how will you manage this case? Would you prefer to perform TAVI or aortic valve replacement? And if TAVI, with which prosthesis and with which strategy? So,
please, Roberto.
Please, Roberto.
Take the stage.
Thank you. So, Antonio, I think this is a very nice case. I mean, it's a very nice example of many clinical situations that we are going to face in the next future. So this is a young patient. Let's not say it's a low-risk patient. Obviously, it's a low-risk patient, but it's a 57-year-old patient. So we have to take into account many things completely different to what we were used to do for older patients, okay? First of all, we need a perfect, excellent acute result. Which is something that we are able to achieve also in older patients, but in this case, it's even more important. Well, we are lucky because he already has a permanent pacemaker, but we need to have zero paravalvular leak, and we have to be sure to use a prosthesis able to let us get access again into coronary arteries, because we know that 57-year-old man could develop during his life coronary artery disease. And then we have to consider future interventions on his valve. So we have to take into account all these things. And also, let me say, we have to minimize the risk of complications, because as we know, for example, vascular complications that according to literature have always been around 9%. They are not acceptable in this type of patients. We have a young patient, so we have to minimize all type of complication. This is the first thing. Second thing is the long term. So we need to choose a valve able to secure a perfect long-term result in terms of durability and also in terms of future interventions. Here you have a summary of the most important clinical trials about the two valves that are mostly used in the world. So the self-expandable core valve Evolut platform and the balloon expandable SAPIEN valve. Well, I have to tell you that these studies are not being they are not dealing with young patients, except for the Notion 2 trial. So this is very important study, a recent study, Notion 2, enrolling patients with an age below 75-year-old, but we have only 1 year data. So we still need time to be sure that the durability of the valve, this is mostly including the two platforms, but mostly self-expanding valves, are enough to give our patients this type of solution, okay? So Notion 2 is probably something that will give us answers. But then we have to consider many things. So I have a question for you, Antonio, before we start going on. So let's, first of all, what valve are you going to implant? Because according to that, we can make a short discussion. And second, how do you imagine the future of this patient, the natural history of this valve during the next 10 to 20 years?
Okay, one of the in our case we choose a SAPIEN valve, and the first reason why we choose this valve, it was that the ring was not small, so we could implant at 29 according to the diameter of the or to the area of the little basal ring, and then we wanted to implant a valve that could guarantee the maximum rate of coronary reaccess, because in a such young patient, the probability to have the necessity of a future reaccess will be really high. And in case of a reduced TAVR, this approach will minimize the risk of creating a sort of cover stent, a very tall cover stent that will be created in the case in which we will implant a tall profile valve such the Evolut valve. So in this kind of patient, we prefer to implant a SAPIEN valve, so a short profile valve. And in the next future, in the remote future, if he would require another valve, another THV, probably will try to perform another SAPIEN, and then maybe again after 30 years, maybe an Evolut.
Yeah, that sounds
This could be his
reasonable.
lifetime strategy approach.
Yeah, that sounds a reasonable strategy, according to me, especially because, well, this patient is not inoperable in general. Let's say you have a previous chest radiation, so it's not porcelain aorta, but the surgeon is not happy to perform surgical intervention on that kind of aorta. But please bear in mind that if needed, these patients can be operated. But we don't know what will happen in 10 to 20 years. Maybe porcelain aorta will come. And I think your strategy is reasonable, because you're planning to put a second SAPIEN valve into the first one. We know that this is not a small one, so the we have not issues about the durability and the gradients, the dysfunction that came during the recent data about balloon expandable platforms. So I think this is a very nice consideration, but always consider that there is still the opportunity to perform surgery. Let's say that this valve degenerates before than usual, and you are worried about something that there could be also a surgical phase 2, and then probably a future valve in valve, like for example in this case. But I agree with you that this case probably a balloon expandable platform is the best solution.
Thank you, Roberto. So let's go further with the clinical case. So as I anticipated, our heart team excluded our patient from aortic valve replacement, and so we decided to perform TAVI. This was our procedural strategy. So we choose to perform an echo-guided puncture of the right femoral artery to obtain the main HS. The secondary HS was in the left radial artery. We performed the rapid pacing through a temporary pacemaker through the left femoral vein. That day we did not have the electrophysiologist with us. And as usual, we performed local anesthesia, like usual in our institution. And then we choose to implant a Sapien 3 29 millimeter valve. Let's go straight to the implantation, the interesting part of our case. As you can see, at the really end of the implant, the balloon burst. As you can see, there was no complication at the implantation site, nor paravalvular leak, so the implant was absolutely perfect. But we could not be able to retrieve the commander delivery system of our Sapien valve. On the right, you can see a bench simulation of what was happening at this moment. That was a transverse balloon rupture that prevented the extraction of the delivery system. So how did we manage this case? We pushed the commander to the aorta until to make it reach the aorta. And then we obtained another HS in the left femoral artery with a large bore 22 French sheet. Through this sheet, we used a Indra snare to snare the wire of the delivery system and extract it from the left femoral artery. Then we push the commander from the right to the left HS until the commander handle was against the right femoral sheet and the pusher of the commander was against the left femoral sheet. At this point, we cut the proximal end of the commander, and when you do this maneuver, you will be able to expose the inner balloon shaft. So what happened? The inner balloon shaft is linked to the distal part of the balloon, while the commander, the pusher, and the balloon catheter, so the proximal part of the delivery system, is together with the proximal part of the ruptured balloon. So when you cut the tail of the commander, you will be able to separate these two systems. And then if you pull the commander from the handle, you will be able to extract the commander together with the proximal part of the balloon, leaving in place the wire, the inner balloon shaft, and the distal part of the balloon. At this point, we could be able to externalize the tip, the distal part of the balloon, to cut away the remaining part of the balloon, and then extract the remaining part of the system from the right femoral artery. We close the right femoral artery with 2 proglides and the left femoral artery with 3 proglides. This was the final results. As you can see, there was just a very small no-flow limiting iliac dissection that required no treatment, and the patient had no clinical events at 3 years follow-up. I'm glad to have shared this case with you, and because I think this is a complication that could happen to everybody, and I think this technique can avoid unnecessary vascular surgeon intervention in such kind of complication. If you want to read more about it, please find here the reference we published on JACC intervention. And thank you very much. I give the floor to Roberto again.
Yeah, thank you, Antonio. I think this is very nice and very smart solution from you. So congratulations from my side. I think we should summarize just some small teaching points in general. First of all, obviously, in this case, it's something that you cannot prevent. We knew that there were calcifications in the root. One of them between the right and the non-coronary cast was speculated, so it's something that could happen. And if you look at the literature, you can see many cases like this showing balloon rupture. Which sometimes is something that you can fix by just retrieving your system without so many trouble. But in your case, you had trouble because the balloon changed its angle compared to the main axis of the introducer sheath. So it's something that you could have to manage. There are many different techniques. I don't want to be technical in this field. You can use the umbrella technique by trying to pull from the base of the balloon, but it's something more risky. So you took the smartest solution by creating the loop from right left side, and this was very nice, especially because you explained us how to separate the shaft of the balloon and the commander. But before that, I would like to ask you, well, in this patient, you have obviously a very nice anatomy, so you're not worried about vascular complication. But as I told you before, you should do whatever you believe is necessary to minimize your complications. So in our center, for example, and I know also in many centers across Europe, we use a small protection of the main axis by putting just a wire into the distal SFA, for example, in your case, in the right SFA, because if something happens, I mean, if there is some small flow limiting dissection or even a bleeding, even a small perforation, you are very quick in putting a balloon and you can use your time to plan a rescue strategy. So in this case, you had no trouble. You had only a small dissection in the other side while retrieving the system. But I would have put anyway, especially in young patients, a small wire to be sure that if something happens, I am protected and I can at least spare time to use my rescue strategy.
Okay.
But obviously, you have
But
to.
Roberto, you use contralateral access, the radial one,
From the radial.
From the radial one, please.
Yeah. Yeah, I mean, we use from the radial one, okay. But in many centers, I know, for example, our colleagues from Catania, they still use the femoral, but it's something that can be obviously decided according to your practice.
And
but it's something that
and you choose in every patient does this strategy, or selecting the most complex vascular access?
No, we use it in every patient. We use it in every patient because it's something that takes you 2 minutes. And also when you don't need it, you facilitate your hemostasis, because you use, for example, a balloon, and then you can use your proglide. We use a sequential technique to be sure that we need a second device. So if one proglide is enough, we stop at one proglide, and then we decide. But we use a balloon also to facilitate hemostasis. In this case, in general, when you have any trouble, I can tell you that it's very helpful to have a balloon, a wire already there, because you don't have, and for example, if you have a small laceration in the vessel, then it might be tricky to put your wire in the distal part because the wire can be trapped inside the small laceration.
So you anticipate any possible complication if there is low rates of this one. And if anybody wants to ask something, anything, please raise your hand or type your question in the chat box. Meanwhile, I have a question. We talk about young patient, not so low STS, not so low risk patient in this case, but young, especially in young patient. Speaking about adverse events, do you which kind of adverse events you fear most in the short term and long term? For example, stroke or patient prosthesis mismatch?
Well, very nice question. Thank you, Julia. Well, for example, stroke, I think it's something that should be feared the most because we know that a stroke in such a patient is devastating. You're completely changing life of a 57-year-old man, which is, I mean, I believe it's still working. So it's something that changing completely his life. So this setting should be, if we want to move, that's a personal belief because we still need data, but data are coming. If you want to move to this type of population, like are doing in US, we should use cerebral protection in everybody. We don't need anatomical high-risk features to use cerebral protection in this type of patient. So I think this is probably the most important thing. And according to patient prosthesis mismatch, it's something that, yeah, you have to deal with, especially for the long-term results, for the durability. That's why I emphasize the dimension of the annulus, so which is in this case was large annulus, so no worries about the use of balloon expandable valve, but it's something that you have to take into account because we still we believe we don't have perfect evidence, but there are different evidence coming to the same point that patient prosthesis mismatch can reduce the durability of the valve and especially can bring more valve dysfunction to our attention, thus increasing the risk of having a TAV in TAV before the period you would like to have it. So in this case, for example, if you are able to achieve 15 years of durability of the valve, you have a great success. But if you have to perform a TAV in TAV after 8 or 9 years, I don't think you are happy because you still need a third intervention during the life of this patient. So I think it's very important to take into account this patient prosthesis mismatch, which is important also in older patients, but it's more important in this type of population.
Thank you. And a question to Antonio. Do you know if also my valve have the same kind of structure and if your maneuver is applicable? Have you any experience about it?
No, I don't have any experience with my valve, but good idea, Marco. I will try with the simulator for my nurses to try the same trick if it works. Nice idea, Marco. Really nice idea.
Do you
Yeah,
think?
I think I don't think
Yeah.
technically it's more complex because if you see the let's say the commander of the MyVal, I don't think you can cut where you cut your. So I think it's technical more complex, and I don't know if it's feasible. I agree with Antonio. I don't know. So it's something that we should look for.
You talk about Notion 2, and Notion 2 raise again the problem of the treatment of bicuspid patient. Do you think that if we want to treat well bicuspid patients with transcatheter approach, do you think that it is more a problem of anatomy of valve phenotype or a THV platform that we should choose?
Well, it's not easy to answer. I think it's probably a combination, because you always look for the proper device for that kind of anatomy. And what we know today is that bicuspid valves are not the same. So we have different type of bicuspid, and it's not just the Sievers classification, type 0 and type 1. Even in type 1 bicuspid, you can have the conic shape, the elliptic shapes, the severely calcified ones, and also you have to consider the distance between the annulus and the raphe. So it's very complex situation, and you have to find the right device to be adapted there. Anyway, I believe that at the moment, with the currently available devices and what we know about bicuspid, very elliptic valve, a lot of calcium, young patients, many times associated disease of the root. So many things together. I don't think we are still at the point of telling that we are as effective as the surgeons. So we still have to say that bicuspid valves are surgical. So probably in the future, we will, I don't think we have to learn about sizing and about positioning, and you know perfectly, as Giuseppe showed many times. So we are probably waiting for novel platforms that could help on that. So maybe changing the adaptive seals and also the radial force of the devices. But still we are behind the surgeons.
Thank you, Roberto. And moving back to cerebral protection, Martina asked if in this case of young patient with calcific aorta, we can use cerebral, or we should use cerebral protection.
Yeah, we said it. Yeah, absolutely, yes. That's it's a matter of reimbursement. That's the only issue. So we are not able to provide all our patients. But if I have to choose one patient to give cerebral protection, it will be this one. So calcified aorta with previous radiation and young age. So we don't have to think that we provide cerebral protection only to high-risk patients, because we are not able to identify high-risk patient. We should give everybody, in particular young patient, because we know that the risk of stroke in this patient, it's dramatic.
Thank you. And Antonio, as you mentioned before, but we cannot identify any factors which can predict balloon rupture during TAVI.
Actually, in this case, honestly not, because there was some spike within the virtual basal ring and the LVOT, but it was nothing really special. There were some classification that we see in many cases, so we could not expect a rupture. And the inflation volume was nominal in this case, so we did not even overinflate the valve. And another interesting thing that I forgot to show was that we performed valvuloplasty before, and the valvuloplasty balloon did not burst. So this is another interesting thing.
Thank you. So I would like to close the session with one final question. Before I just want to thank Antonio, to thank Roberto for being here today. But do you think that we are ready to move from 75 years of cutoff in our guidelines, European one, to a lower age cutoff for TAVI?
Very nice question. I have to. I am usually skeptical in general as a person in my nature. I have to tell you, I don't think we are ready, 100% ready, because we still need long-term data about this type of population. luckily, in US, they already performing this type of intervention before 75. So we will have data very soon. And I think that we will be ready very soon, because my feeling, and also what's your experience, I know, is that this type of patients perform very well with TAVI. And I don't think we are inferior. I think we are superior to surgery also in this type of population. So I think we will be ready very soon. And if you want me to conclude with take-home messages, first of all, I want to thank you for this very nice invitation. But I think that Antonio showed us a very nice example of what we are going to face in the next future, because we know that the evidences of TAVI advantages over our aortic valve replacements in younger and lower risk patients are increasing and will increase in the next future. To confirm this trend, anyway, it's very important that we keep on going how we are doing. So reducing complications in general, including vascular complications, risk of paravalvular leak, risk of permanent pacemaker. So these are important in general, but in particular for this very young population. Especially because in many times we know that the risk scores often overlook relevant clinical variables, and we are not able to, I mean, we are speaking about surgical risk, but we should speak about TAVI risk now. There are features that have to be taken into account when performing a TAVI that are not in the surgical scores. That's why we have to be perfect in our practice. And so we need to learn how to deal also with this type of complications that could happen without using cruent and without asking our surgeon to intervene, which is something that could happen, but it's better if we can avoid it, especially for the patient.
Thank you again to Roberto. Thank you to Antonio. It was an amazing session. And so I wave to everybody, and please see by the end of June for the first statistical corner. So have a nice day to everybody.
Thank you.
Thank you.
Thank you.